But now let's focus on the dissatisfied part. Injection patients are much more dissatisfied than are pump patients. That's just with the management of the diabetes. Now let's turn to the issue of whether or not I can live with it. Can I go about the business of being a mother, an employee, a coach, a student? Can I live with my diabetes? Once again, very satisfied and satisfied occupy most of the pie, but again, the pump does better. And again, if we look at the issue of dissatisfaction, it dramatizes the fact that if you've got to do the multiple daily injections and you've got to carry around all the equipment, it's much more disruptive on your lifestyle than is the pump. So the first preliminary inclusion is that no matter how we look at it, now we've not broken it down by gender or race yet until we have all the data collected, the insulin pump is a far more effective tool in allowing people with a chronic disease to get on with their lives and continue to be productive citizens. We've got some interesting observations where we've learned that there are holes in our whole approach. First of all, although insulin management is improved, however you do it, if the patient in their prior life had a severe hypoglycemic reaction, which could be unconsciousness, could be seizures, no matter which technique you use to improve their control, to get rid of the variation in their glucose control that produced that severe hypoglycemia, the fear never goes away. Once you've experienced it, or once a family member has seen someone experience it, the fear never goes away. We really don't address that in most of our daily therapy. The second point is a huge flaw in the way we administer or prescribe insulin pumps. We ask the patient, the significant other, if the patient became hypoglycemic and unconscious, would you know how to turn the pump off? And the answer was no. So there's the patient in a hypoglycemic episode, and the person they're most dependent on to help them with their diabetes doesn't know how to turn it off, because all we normally do is teach the patient about the pump. We don't include the significant other in our teaching efforts. And some of our anecdotal results are very surprising. Remember, I told you insulin pumps are only prescribed for type 1, which tends to be the young. And I love this one. The insulin pump interferes with some activities. It affects swimming and what I look like at the beach. I don't like that. And the person who submitted that comment was in our 60 to 70 year age group. So what we're concluding is that while insulin management, intensive management of diabetes can be accomplished with either approach, both patients and the people who watch them or are interacting with them prefer the pump. It's less intrusive. It's more enabling. And it's true for type 1 or for type 2, but only type 1 is currently approved. It's also true irrespective and independent of age. And at the moment, the more you age, the more likely you're to have type 2, and the more likely you're to be covered by an insurance that doesn't recognize the pump. So our primary objective in the whole study, and here is already being validated in that our results when we're done, we believe will induce and justify a reconsideration of third-party coverage for an upfront investment in an expensive piece of technology in order to provide long-term better care and continued productivity of the citizens. And the second is that we've got to expand our educational efforts when we use this tool, because it's not just the patient who's directly involved, but the people who surround the patient. Thank you for your attention and for inviting me to participate. Thank you to InHealth for their generous support of the research.
Who is Director of the Center for the Evaluation of Value and Risk in Health at the Institute for Clinical Research and Health Policy Studies at Tufts University, who is doing some very interesting work on willingness to pay in the realm of diagnostics, which is significantly different in every way from therapeutic devices, and the methods of studying them must also be quite different. And Peter's got some ingenious ways of looking at these issues. Peter.
Okay, well, good afternoon, everyone, and thanks very much, Steve, for that introduction. I don't know about ingenious, but I'll do my best. We very much appreciate InHealth support, so we thank you very much for that. And, you know, the review process was scientific, and InHealth said this would really be hands-off and it would be independent, and in fact, that's exactly the way it's been, so we appreciate that. So I want to talk about value of healthcare, in particular value of diagnostics. And there's been a sort of history of people wondering about whether we're valuing diagnostic information appropriately. And we'll talk about some new research that my colleagues and I have done to try to think about this. So first I should acknowledge my co-authors at Tufts and Harvard, and again the support by InHealth. Predictive testing, in vitro diagnostic testing, really any diagnostic testing, promises more accurate diagnosis and prognosis. There are lots of new applications, Alzheimer's disease, cancer, on and on. There are questions about value, questions from payers about whether it's delivering the kind of value that they should reimburse for. And also the sense that the conventional cost-effectiveness analysis might not be getting at value, in the sense that traditional cost-effectiveness analyses are done and cost-effectiveness is modeled, and diagnostics have value to the extent that there are treatment consequences, right? So a diagnostic is considered without value if there's nothing you can do about it. You know, think of a test for which there's nothing you could do about the disease that you find. You know, why would you want to reimburse that because there's nothing you could do about it? At least that's one often hears that. Now, of course, there might be value of just knowing that information, even if there are no treatment consequences. So in this study, we're trying to understand and quantify that potential value of diagnostic and think about whether that should be added to traditional cost-effectiveness analyses. Let me just say, I am someone who does a lot of cost-effectiveness analyses and directs a research group that does these kind of analyses. In particular, we have a database of cost-per-quality analyses. And I am an unabashed supporter of cost-per-quality analyses. I think they have a place in decision-making. I think there are a lot of limitations to qualities, and I don't think those two things, you know, are sort of, they can't coexist together. I think they can. I think qualities gives us a rough guide, a benchmark of sorts for informing decision-making, but we need to understand value at other levels.